Okay, we're going to start the hepatic biliary system. I'm not going to lie, this is a little bit complicated, so I'm going to do this in several parts so you can break it down and study one part and move on to the next. So when you hear the word hepatic biliary, when we're talking about hepatic, it's pretty much just the liver, maybe the common bile duct, but the biliary system is then the gallbladder and the pancreas. So that's what we mean by hepatico-biliary system. So let's get started with some of the hepatic system. Super important that you understand the anatomy of the hepatico-biliary system. You got your liver, biggest organ outside after the skin. Biggest internal organ is your liver. Liver is one of the only organs in the body besides the skin that can regenerate itself. So it is possible to do a living donor liver transplant where they can take a piece of the liver, transplant it to somebody else, and then both of those will regrow. So this is the liver. It comes all the way over on top of the stomach. You can see the outline of the stomach here. This is a spleen under the stomach. You can see the pancreas comes up here like this, and this is the gallbladder. The liver is extremely vascular. A ton of blood gets filtered through the liver. And here's the gallbladder, and it comes down, and you've got a bile ducts here. One of the things that the liver does is to produce bile, and it stores the bile in the gallbladder. And you'll see here you've got some bile ducts here that come out, and it comes out of another word for gallbladder is chole, C-H-O-L-E. And this is the common bile duct here, because the bile ducts will come out of the liver, one comes out of the gallbladder. And the pancreas also has a bile duct that comes out, and so where they all attach comes down into here is the common bile duct. And when a person eats in their stomach, especially when there's fat, it triggers the gallbladder to squeeze the bile that it's holding, pushes it down through the common bile duct into the small intestines, where then it'll start breaking down fats. This is very important to understand these ducts, and we're going to talk more about it as we go along, because if these bile ducts start getting blocked, the patient can start getting jaundice. So it can get blocked up here in the pancreatic duct, in the common bile duct, out of the gallbladder duct. So just make sure that you're understanding what the hepatic system is and what it does. So the liver is responsible for all kinds of things. Like I already said, it produces bile. The other things it does is it synthesizes the amino acids. So when you're eating amino acids, which you need to be eating, they're very healthy for you. It will start synthesizing that as a breakdown of some of the proteins. It converts ammonia to urea so that can get excreted in the urine. So when your liver is not working, that's why the ammonia levels start getting very high. The brain does not like high ammonia levels. That's what causes the encephalopathies. And it does a lot of mechanisms involved in clotting factors. So if your liver is not working, the patient is also going to have some bleeding disorder. So the liver is a fairly complicated organ, fairly necessary. I'd like you to know some of these lab values. These are also listed in your textbook. The things that I kind of want to point out, your bilirubin counts, you're probably not going to be asked what normal bilirubin is. You just need to know that if your patient's bilirubin is high, your patient will become jaundiced. And there's direct and indirect. So bilirubin is the byproduct of dead red blood cells. So when the red blood cell will live about 120 days, about 3 months. When it's done doing its lifespan, it will die. It breaks apart, and part of that is heme, and the breakdown of heme is bilirubin, and that the liver is responsible for conjugating that bilirubin, and then it's excreted in the stool. And the reason that stool is brown is because of bilirubin. That's what the liver does. So when the liver isn't working, it can't conjugate the bilirubin. The bilirubin does not get mixed with the stool. It's not excreted in the GI tract. So where does it go? Floats around in the bloodstream. So instead of it going out through the stool, builds up in the bloodstream, and the patient starts getting jaundice. So the reason the skin turns yellow, the eyes turn yellow, the sclera is yellow is because of high bilirubin, because now it's in the bloodstream and it's not excreted in the stool, and at the same time you'll see the stool becoming clay colored because the bilirubin that's supposed to make it brown is now floating around in the bloodstream. So that's why bilirubin is important. The numbers on this are fairly low. If you'll just remember, none of the bilirubins should be higher than 1. And that makes sense because it should be in the stool, not in the bloodstream. So if it's getting higher than 1 milligram per DL, it's too high. You should not have bilirubin in the urine. That should never be there. So when you do start spilling bilirubin in the urine, it's too high in the bloodstream. The other things that we look at when we're looking at our livers is ALK-Phos, ALT, and AST. Those are your classic liver enzymes. So your ALT, it should be about 5 to 35, AST is about 5 to 40. I think your book puts this at both of these at 5 to 40, but if you can remember, your AST and ALT, classic liver enzymes, really should not be above 40. Once both of them start getting above 40, you got a liver problem. The reason the prothrombin time, your PTT, is important is because those are your clotting factors. And what we look for in our PTT, a prothrombin time, is our I'll get it. Your international, no. Now I can't remember what it stands for. The international normalized ratio, that's it, international normalized ratio. And that should be between like 1 and 1.4. That's an important number to know. You need to know your clotting factors. That's super important because you need to monitor that. So like if your patient is on heparin or Coumadin, you're going to want this number about 2 to 3 times higher than that because that means your blood is thinner. And so this number, the liver is responsible for this, partially responsible for it. And it really matters in your patients who you are wanting to deliberately keep anticoagulated, like in your patients who have had atherosclerosis, MIs, things like that you want to keep their liver, their blood thin. So you want to keep their INR 2 to 3 times normal, and this is normal. Normal is about 1 to 1.5. Serum albumin protein. So that's another thing because your liver is really responsible for the synthesis and breakdown of protein. When you're looking at protein in lab values, we follow the albumin levels. That's really important. So your albumin levels should be between like 3.5 to 5. When it starts falling below 3.5, you're going to start seeing some problems. Like your patients are going to be more prone to getting decubitus ulcers. They're going to have more difficult time healing their wounds because, as we've talked about a million times, you need that protein to build muscle and to restore muscle. And so when your protein levels are low in the albumin, when it's getting less than 3.5, your patient's going to start muscle wasting, not healing their wounds, prone to decubitus ulcers and things like that. So those are some of the liver enzymes that are important for you to know. You're probably going to see some of those on both my test and on NCLEX, because those are important ones to know. So next, let's talk about what are some signs and symptoms of liver disease. How do you know that your patient's having some trouble with their liver? First of all, you want to get a good history. So if your patient has ever had a history of hepatitis, if they tell you they've got cirrhosis, if they tell you they are a heavy drinker, they have a history of IV drug abuse, those are some big triggers, and you need to start assessing, could they have some liver damage? So step one, you're going to start looking at their lab values, and then look to see if they have any other signs and symptoms of liver disease. They're going to be very, very tired, very fatigued. They're going to have some upper quadrant pain. By upper quadrant, we're talking in the right upper quadrant, right under the rib cage. Now, when you're palpating somebody's liver, you should not, you have them lay flat, you don't do it when they're standing up. You lay flat, and you can press under their right flank right here, and you press your other hand. I think there's a diagram in your book about how to do this. You press your other hand under that rib, and you palpate for the edge of that liver. You should either be able to just barely feel the rim of the liver or not feel it at all. If you do, that's called hepatomegaly. The liver's enlarged. You've got a problem with your liver. You do the same thing on this side with your spleen to identify if your patient has splenomegaly. Those things, when you palpate them, should not, typically in a normal healthy person, should not be able to palpate those. This right here, see all these veins right in here? A couple things I want to point out about this guy when you are assessing this patient. First of all, do you see how his abdomen is slightly distended and enlarged? That's called ascites, and it's different than just an obese abdomen. It's a fluid-filled abdomen. I'm going to show you some pictures of what that looks like. And these signs, these veins here, they're very large, tortuous kinds of veins. That's called caput medusae. This word right here, caput medusae. Caput medusae is that Greek goddess that has those snakes coming out of her head. She's the goddess of caput medusae. That's where they get this from, because it looks like snakes coming out of her head. And that's a sign of liver disease, because of all those vessels that are going into the liver, all the vessels in the arteries that come out are getting engorged. And you can see it here. So that's a sign of liver disease. Mesenteric veins. You get all kinds of mesenteric veins, and I've got a picture of that. It's a little different than caput medusae, that kind of is more tortuous, but there's a ton of, like, you can see the veins on top of the skin. That's a classic sign of liver disease. This word, sclerosing cholangitis. Remember how I told you this word right here, chole, means gallbladder. So sclerosing is the word for it's getting hard. If something's like sclerosed, it's hard and stiff and fibrotic. So sclerosing cholangitis is the gallbladder and the common bile ducts are getting very thick and very hard, so it's going to start backing up bile, and again, it's going to lead your patient to getting jaundice. They get all kinds of varices. They can get esophageal varices because going back to the anatomy, you can see how close that esophagus is. So when all of the arteries and the veins in the liver are starting to get backed up, it pushes up into the esophagus. They can get esophageal varices. They get mesenteric varices. Basically, all of the veins that are supposed to be coming back to the right side of the heart are getting congested and filled up. So those are some signs, but wait, there's more. You can get a bunch of different kinds of jaundice. Your book does talk about the different kinds of jaundices. You should know what they are. I'll think of it. I've just lost my train of thought. I know it's in your book, it's not congested. What is the word? I'll think of it. I'll come back to it. Petechiae or ecmotic areas. The patient will bruise very easily because remember, your liver has a lot to do with clotting factors. When the liver is not working, your patient's going to start bruising very easily, getting specifically like this thing, spider angiomas. See how they get, like an angioma is like a little red patch, but you probably can't see it from there. Google a picture of it if you can't see this. But there'll be like a center spot, and then they kind of spider out like that. That's called a spider angioma. Palmar erythema, they can get red palms. Portal hypertension is a big one because the arteries that are going into the liver are also getting congested. So basically it's high blood pressure in the liver, and they look very malnourished. So they'll have these big bellies, and they give the appearance that they're obese, but their limbs look very malnourished. I'm going to show you some pictures of that. So all of these are signs and symptoms that your patient has a liver disorder. So then when your patient starts, the ammonia levels start getting high, and you'll remember I just told you that the liver breaks down amino acids into protein, into uremic acid, and it's puts into the bloodstream, excreted by the kidneys, like we talked about last week in renal stuff. When that's not working, the ammonia levels, which are supposed to get excreted in the urine, is not getting excreted because the liver has stopped its function. It's not breaking it down. So the ammonia levels now get released into the bloodstream and start building up in the bloodstream. The brain cannot stand high levels of ammonia. And that's one of the, it's a later sign, but it is a sign that the liver disease is getting really bad, is when those ammonia levels start increasing. And so you're going to see a lot of neuro problems, especially in later stages of both hepatitis and cirrhosis, called hepatic encephalopathies. This is ammonia levels in the brain because the liver's not working. And so you're going to see things like the patient's going to get disoriented, they're going to have personality changes, they're going to have some memory loss. They will do this thing called asteristics, and it's a flapping tremor of the hands. When you have them hold their hands out, they do this flapping tremor. However, it can be subtle. If you read it in the books and stuff, it all acts like, they're going like this, but that's not the case. I'm going to show you this in a minute. They can get this sulfurous odor to their breath. And again, that's just because of toxic levels that are now in the bloodstream and have not gotten eliminated through the GI tract because the liver is no longer processing those things. And so I wanted to show you a little example of what asteristics looks like. So you have your patient hold their hand out like this. See, it can be that subtle, but see how she cannot hold, she should be holding her hand right like this, and she's not. She can't do it. See how she's kind of doing that? You can also see she's got some clubbed fingers there. That's called asteristics. And when you start seeing that, your patient probably has, okay, I can never remember how to get back out of here. Okay, one moment, please. Before. There we go. Okay, I'm gonna go back here. Okay, so that's what asteristics is. So if you see that, that's a bad sign. The patient's getting pretty bad. Okay, so esophageal varices. I already told you a little bit about this, but remember that caput medusae that I showed you? You could see on the outside of the liver. Well, this is what's going on inside the esophagus, and we talked a little bit about this when we did GI week. But another major cause of esophageal varices is liver problems and portal hypertension, because the arteries are getting so stiff in there that it's getting backed up, and the first place it's going to go is the esophagus. The esophagus sits right in the middle of the liver, basically. So you have to watch for this. You can see this patient's already bleeding a little bit. So if your patient starts vomiting, if they're coughing, if they're eating something that's a little bit sharp, these can easily rupture, and you can lose a patient this way. This is a very common way for your patients who have liver disease will ultimately die because of esophageal varices. So you need to be aware that this is a complication of liver disease and what to do about it when it happens. So if you have all of those known factors, patient's liver disease, their lab values are off, they've got all the signs and symptoms, and all of a sudden they start coughing up or vomiting up blood, especially bright red blood, they've probably ruptured an esophageal varices. So one thing that you can do is put in this Blakemore-Stevenson tube. And I talked a little bit about this during GI week, but this is what you do. It looks like a Foley catheter, but you just put it down like you would put an NG tube, except you just put it right in the oral airway, especially if they're actively bleeding. If they're not actively bleeding, you can maybe put it through the nasogastric tube, but you put it down, you put this part into the stomach, so it secures it there, and then they blow up this part of the balloon, which would sit right in here and tamponade this down. It would smash that down, and it's equivalent to like putting pressure on an artery. And so the patient would just sit with that there until the bleeding is stopped, and then you make sure that they're off their anticoags and get that PTT back down if they're up, if they're on anticoags, and up if their INR is 2 to 3 times normal. The other thing that they can do if an esophageal varice is starting to bleed is use a medication called vasopressin or pitressin. What those do, they've got very potent vasoconstrictive properties, especially in the splenic portal and intrahepatic vessels. So these drugs are very specific to these vessels. They will have some effect in other places. So if your patient is bleeding, sometimes you can put them on this and it will constrict these vessels, and it will give your patient more of a chance to get that bleeding to stop. Sometimes when you're giving these medications, they're vasoconstrictive. You do need to also be careful, because you don't want those coronary arteries to also vasoconstrict, because that can lead to an MI. So sometimes the patient also needs to be on nitroglycerin to kind of open up those cardiovascular arteries. So you're kind of playing a little bit of catch up when you've got a patient who's got this level of disease in their esophages and liver, because you don't also want to cause an MI by giving vasoconstrictive medication. So this gets a little bit tricky. So if your patient is got this going on and you put them on vasopressin and Blakemore Stevenson, also make sure you're watching for that MI because that's a pretty big risk factor. So your patients who have liver diseases are very, very sick, especially the worse it goes. So what do we do? What do we do for the patients who have a liver disorder? First of all, we want them on low sodium and a low protein diet, but not a no protein diet. So this gets a little bit tricky because the low sodium, obviously, so that they don't hold fluid in, but the low protein diet because they have to have protein in order to heal and repair, but you don't want too high protein levels because that's going to contribute to the high amino acid or high ammonia acids as well. We put them on diuretics that will help prevent ascites in the belly and paracentesis sometimes. So if the ascites get so bad, I'll show you this in a minute. If the ascites get so bad, and that's just fluid in the peritoneal space, then we can pull it out just with a paracentesis, like just like how, remember in Cardiac Week we talked about pericardial centesis, where you just actually are pulling excess fluid around from the heart, where you do the same thing in your patient who has severe ascites. There is a procedure, a surgical procedure called a TIPS procedure that is sometimes used in patients who have really severe portal hypertension, and it is, and I'm going to show you a picture of it, I think, if I don't, remind me. And it is a procedure where they go out and around some of those enlarged, engorged veins, and so it will offset some of the pressure that's in those veins, leading to some of those varices. We put these patients on bed rest. We want them to heal. This is not the time we want them up walking around. Sometimes we have a peritoneal venous shunt where we're going to take some of that excess fluid that's all stuck up in the abdomen, up near the liver, and we are going to shunt it away from the liver. And in the abdominal cavity, we're going to monitor labs, and those are the labs I just talked about, whether their blood pressure low, the shunts and the ports I told you about, and always assess them for bleeding. So we're going to put them on precautions so that they're not using razors, they're not doing something that's going to cause them to bleed, because the bleeding issue is such a problem, and we don't want the patients to bleed to death, especially the esophageal varices. This is what ascites looks like, and you can see how expanded and engorged, even pushed out his belly button. But if you can just kind of see up here, see how thin and emaciated his arms look, and you can even see down here that his legs are smaller. So this is an indication. They almost look pregnant. It almost looks like a pregnant person, and that's what ascites is. That's a late stage. This is what it looks like inside. So this guy's now in the OR. This is the surgeon's hand. These are the loops of bowel, and this is all ascites in here. It's all excess fluid in the peritoneal cavity. So we need to get rid of it. One thing that we can do is paracentesis. So you have the patient sitting up, because when they're sitting up, now the fluid is down in here. And then the healthcare provider will just go in with a large needle. Usually this is hooked up to a big bag, because it's not uncommon to have 1,000 to 2,000 milliliters of fluid in there. So they'll just put a needle in there and drain this out. You do need to be careful, because sometimes if there's so much pressure in here, the bladder can rupture or get a fistula in it. And if there's a fistula from the bladder, by fistula I mean like a tunnel, like an abnormal tube that the bladder should be contained, but it's not. Some of this ascites can then drain into the bladder, and then you'll get it out in the Foley catheter bag. So the catheter bag just keeps dumping out a bunch of fluid, so that is an indication that you might have also a problem with the bladder. So just another problem to think about with your patients who have liver disease. They are very prone to fluid volume overload. They're carrying 1,000 to 2,000 milliliters of ascites in their abdomen if they've gotten to that point. So we need to be very careful in our patients who have liver disease to avoid fluid volume overload. So you are going to implement precautions like you would with anybody else who has fluid volume overload. So you might have to put, sorry about the dogs, you might have to put them on diuretics, which is going to help get rid of some fluid. Put them on fluid restrictions. You're not just going to have the glass of big jug of water right there. Patient positioning, like you just said, it's obviously going to be much more conducive for the patient to breathe if they're sitting in an upright position. You do also need to be careful with the use of diuretics in your patients who have liver disease. One diuretic that we give our patients is spironolactone, aldactone, and it's a great one. It does not waste potassium like Lasix. It's not one of the ones that's a potassium wasting because it doesn't work in the loops of Henle like Lasix does, but it can lead to gynecomastia, meaning the development of breast tissue in men, which is usually uncomfortable for men. So you do want to be careful of that. And you do, if you have to take your patient off spironolactone or aldactone and put them on another one, and you put them on a loop diuretic, now you've got to be also careful about your hypokalemia. And remember, your potassium needs to be between 3.5 and 5. When it gets less than that, we're looking at hypokalemia. So if they're on a loop diuretic, because of fluid volume overloads, always check their potassium. And then if their potassium does start getting low, you better put them also on cardiac monitors because their heart is not happy with low potassium levels. And then a lot of your diuretics can also cause gout. Gout is like that sandpaper in the toes. It's very painful, but a lot of the diuretics that we use for patients who have hypertension can also lead to gout. So so those are some things you have to manage while you're trying to take care of your patients who have liver disease. Okay, so that's an overview of liver disease. I'm going to stop the tape there. And so this will be part one. This is an overview of liver disease. Then I want to talk about the specific types of liver disease, knowing that all of these, we're going to talk about hepatitis and cirrhosis mainly. Those are your two big ones. So I'm going to tell you about those. But both hepatitis and cirrhosis can cause all of those same symptoms that we just talked about. So all the symptoms, the side effects and everything are a result of these next two diseases, maybe three because we're going to talk about liver cancer. So make sure that you know that stuff, and now we're going to move on and talk about the specific liver disorders that are causing all those things I just talked about. So, okay, take one or two, whatever we're on.